Welcome, everybody, to another episode of Dr. Matt and Dr. Mike's Medical Podcast. This is our long-form episode where we don't spend 10 to 15 minutes going through our A to Zs. We actually spend a good amount of time having a nice chat, and today we're doing listener mail and answering listener questions, which we do.
It's good that you got that right, not call it the mailbag.
The mailbag, no, that was your nickname. No, we've got to call it listener mail. We're going to do, what, one a month-ish?
Yep.
We get a lot of questions, we get a lot of emails, and it was very difficult to get back to everybody. So we thought that this is a really nice way of acknowledging you, because it's because of you that we do this. If you keep sending us nice emails, we'll keep making podcasts okay. So it's a bad start to saying we'll keep making podcasts as best as possible. We're going to start with some listener mail. Well, I should always ask, how are you?
Well, thank you.
Okay, who cares?
It's raining outside.
Yeah, crappy day.
It's cooler. We've had a switch in Queensland from the hot, humid summer with a million cyclones.
Yeah.
To
busting all the trees down in your front yard.
Now it's... Did you notice the change?
Not really.
Not really?
It's still humid. Still stupidly
raining,
humid.
so...
It's raining. So anyway, first email from a listener. This is Amy, and the subject is osmoregulation. Amy states, hello, I'm so sorry to contact you about this. Don't apologise. But your videos have been life-saving as I start my career as a paramedic. Never, ever apologise for thanking us. The way you explain the topics has helped me hugely. I was wondering if you had any videos about osmoregulation. I'm struggling to find anything on this topic, and I'm unable to find anything on your YouTube page. Thank you again. Honestly, you guys are amazing. Amy.
Well, thank you, Amy.
Thanks, Amy.
And good luck in your studies.
Yes, especially starting as a paramedic. A good friend of ours,
Sandy
Macquarie.
He's champion.
He's
teaching for me this semester.
Yes, he's a good dude.
He's converting all my students to paramedics.
No, he's great. He loves, he works on movies as a paramedic. Listen to our episode. We did an episode where we spoke to Sandy about his career. It's quite interesting. Anyway, you asked the question about osmoregulation, which for those who don't know, it is basically water balance. It is the concentration of fluids in your body and maintaining that balance, regulated mostly by the hypothalamus at the base of the brain. I have done some videos that touch upon osmoregulation. So I've done a fluid balance video, which I suggest you look up on the YouTube channel. I have done a video on the hypothalamus and ADH, so antidiuretic hormone. But maybe I need to do an overarching video on osmoregulation that talks about the thirst reflex and the specific role of the hypothalamus and so forth. So, Amy, you have convinced me. I will create an osmoregulation video just for you.
Should we do a podcast on it? Have we done a podcast on body fluids?
We've done it on the hypothalamus, and we've spoken in. Yeah, who knows? We've done so many episodes. We'll get back to you about whether we do a podcast on it, but definitely a video. Do you want to read the second one?
Sure. So this is from Kristen. And the subject here is the pathophysiology of vasomotor symptoms in menopause transition.
That's a big one.
So the message is, hi, I love your show. I'm a nurse practitioner in the US, that's United States of America, Michael,
okay. Yeah.
and treat a lot of women going through menopause changes. I'm studying for the Menopause Society certificate, exam, and trying to better understand the pathophysiology of VMS. And I'm finding that there is, tragically, a paucity in information here. Do you have any insights that may help? Thank you very much for all you do. I hope to come and see you in person one day.
Oh, that would be awesome. Thank you, Kristen. You come to Australia, let us know. Okay, so firstly, we don't have any videos or podcasts on menopause. However, I've just finished a batch of female reproductive and male reproductive system videos on the YouTube channel, and I need to do a video on menopause because I spoke about the reproductive life cycle. However, I didn't talk about the full life cycle because I basically finished at reproductive age. So I do need to do a video on menopause, which then will allow me to go into the literature about vasomotor symptoms. Do you want to talk about vasomotor? Because it's something that's affects you deeply?
Right now.
Or do you want to just briefly talk so people know what broadly vasomotor is referring to?
I guess it's just the control of the diameter of the vasculature via the nervous system, and that's generally done with the autonomic nervous system.
Yeah.
And I'm guessing you're alluding to the fact that I don't do that overly well when I have bouts of vomiting.
You pass out, don't you?
So I have syncope.
Into your own vomit. Naked.
So I have naked.
You were naked last time, weren't you?
Well, no.
Oh, okay.
I was on the lawn.
Maybe that's just what I imagined. You're on the lawn. Weren't you mowing naked? Don't you?
No.
I thought you did a nude mow every Saturday afternoon because your neighbours keep complaining. So, so vasomotor symptoms in menopause transition. It is not something I know about, in all honesty, right now, or at least not much. So, but it gives me the opportunity to do research on it and make a video. What do you think?
I agree.
We should do an episode on menopause.
Yeah, and perimenopause.
Absolutely. Yeah. Would need to do a lot of research and get some experts in.
Maybe we should get an expert on.
I think get an expert on. Yeah. So we also have, in addition to our listener mail, we've got questions that require answering. And so I think it's important for us to say that in regards to the questions we get asked a lot of questions about people's personal health conditions and medical conditions, asking for advice or medical support in some way, or medical advice in one way or another. Please know that we can't provide any medical advice. We're not qualified to do so through this mechanism. We don't, or any mechanism. We don't know you. We don't know your situation. And at the end of the day, you really need to go see your physician, your primary healthcare physician, and get the medical advice from them. What we can do is what we usually do and work off first principles. We can talk about the anatomy, physiology, pathophysiology, and pharmacology of conditions broadly that are broadly applicable. But when it comes to very specific scenarios and situations, please know that we cannot give you any advice. We can just talk educationally.
In generalities, yeah.
In generalities. So in saying that, we've got an email from Swati. Swati, the subject is gastroenteritis seizure. And the email says, my 16-month-old was having episodes of vomiting and on the way to the hospital had their first seizure of their life. Once he was hospitalised, he had a couple more. He had bad watery diarrhea. He was put on Keppra and they stopped. Can there be a link with diarrhea and seizures? All his reports are normal. So again, we can't talk about this specific case, but we can talk about what can happen when individuals have diarrhea or vomiting or fluid loss and what that may mean for the environment of the neuron.
Yeah, and seizures.
Yeah. So do you want to start or me?
Yeah, we can start. So I'll start with seizures as a phenomenon. So yeah,
go. Because then I've got a paper that can
link the two together.
Yes,
right. So in your nervous system is brain, spinal cord. It's made up of functional cells, which generally are termed neurons, which are excitable cells that send electrical information to one another. And to do that, they have to pass ions, which are charged atoms, across their membrane.
Yeah, and electrolytes, salts.
Right, that's right. So it's not like electrons like electricity, but they're doing it through electrochemical means. Now, for the neurons to do that effectively, they have to manage their resting potential well and allow the transfer of these electrons in a coordinated manner.
Not electrons, electrolytes.
Electrolytes. Yeah. And so if this is disrupted, so if the neurons don't get this quite right, what ends up happening is the way that the neurons fire becomes uncoordinated. And if it does it in a kind of excessive manner, hyperactive manner, it leads unpatterned manner, it leads to an event commonly known as a seizure.
Yeah.
Okay.
So there's many different types of seizures.
That's right. And so seizures can then be broken down by a number of ways. One being what part of the brain is affected. Mm-hmm. So if a lot of the brain is affected, so significant regions, that's generally known as a generalized seizure. Whereas if it's pinpoint in one section, it's known as a focal seizure. Now, depending on what part of the brain is affected would determine kind of what the symptoms are involved.
Yeah.
Now, commonly, it's going to be impacting the motor region of the brain.
Yep.
So what you'll end up seeing is the body, which has been innervated and controlled by that part of the brain, will impact the way that the muscles move.
Yeah.
And these muscles can be in a tonic form where they become kind of hypertoned, stiff, or they can be clonic, which is they kind of move, and then they could do a kind of a combination of both where they go stiff, contract, and that's kind of that's right. And so that's kind of the convulsing that people would see and tend to associate with a seizure. There can also be tonic seizures, which are sometimes known as drop seizures, which is you go limp and you just kind of completely go flaccid. So a whole array of symptoms can occur as a result of the seizures. And so it really is then dependent on trying to figure out what is the mechanism for that.
Yeah.
And so if a person was to have a seizure, as in this case with the 16-month-old, what would happen when they come to the hospital in a situation like this? They would try to figure out what is the cause behind the seizure. So they would do a whole lot of screening tests to try to figure out what's the cause of it. Now, in terms of the common causes of seizures, one way that we can look at that is through a mnemonic that stands for, is vitamins. So VITAMINS.
Okay.
And each one of those
can be a cause.
Is a cause. So start with a V, vascular. So if the blood supply to the brain is impacted, and this could be done through strokes, ischemic strokes. So whether that is by a clot or whether that's by a hemorrhage, that would impact the blood flow to a region of the brain, and then that would not allow those neurons to coordinate their activity well, and then you could get a seizure. Okay, so that's V. Next one is infections. Generally, this is referring to infections in the brain. So this would be like meningitis or encephalitis. Yeah. I can't comment here whether a gastrointestinal-based infection would have an impact in this eye part. So I'm not going to make a call there, but generally, from my understanding, infections is more brain-related. Then you go to trauma, T for trauma, and that would probably be more head injuries. So if you would have had any degree of impact to the skull or head, that could then impact the brain's firing potential. So after a concussion or something like that. Then we go to A, autoimmune. So these are conditions where, particularly if they're systemic, like lupus, where a lot of the immune system is impacting a lot of widespread different tissues. So lupus, there's a lot of because it's
if you've ever watched House, it's the cause everything's of everything.
Lupus.
Everything's lupus
because it's the antigen that's seen in this autoimmune reaction is nucleic acid. And so every cell's got DNA or an RNA.
Exactly.
So that's going to be a problem. Then we go to metabolic. So this is potentially where it's more related, should I say, to this particular case. So metabolic.
Possibly. We don't know.
So this is relating to things like electrolytes. So what sometimes happens with gastroenteritis, where there is profuse loss of fluid either through vomiting or through diarrhea, you are not only losing water, but you're losing everything that's dissolved in it. And that can be the electrolytes. It can also be acids and bases. And so as a result, this could impact these bodies' levels of things like sodium, calcium, potassium, and acid base. And so working off that principle, if there was imbalances, there is the possibility that neurons can misfire or not fire in a coordinated fashion due to electrolyte imbalances.
Yeah.
Then we go to idiopathic. Now, this is interesting because idiopathic just generally means that's going to be epilepsy. So when a lot of people hear seizures, they generally just think straight away epilepsy. But epilepsy technically is an unknown cause of seizures once you've ruled everything out, that it has an ongoing, so recurrent seizures. And that would be the actual definition of what epilepsy is. Do you want to keep going?
Well, you gotta finish.
So
vitamins is a big one, that's for sure.
N stands for neoplasm, so that would be tumours. Yep. So that would again be involved in the brain. So if you were to have lesions starting to grow within the brain tissue, it would impact that local area, but start to press on certain brain regions, which would cause their misfiring. And then S, sometimes this can be known as syndromes or psychogenic, even though that's a P. So that could be things like, an example could be in pregnancy. There's certain states that can lead to seizures.
Okay.
Yeah.
So there's a lot of things. Yeah.
So seizures they're a symptom of something else.
Yes.
Okay. So they're not in and of itself.
Yeah.
They are a symptom of something else happening in the body. So in this case, by having an infection, which then can lead to changes, there is the possibility, or it is at least plausible, that through, as I said, electrolyte imbalances, there is that possibility.
But it may not even be that, because this study highlighted. So
you had a study?
Yeah, and nothing about electrolytes. So more so about the actual infection itself that causes the event. So a paper published in 2021 in the journal Scientific Reports looked at a possible correlation between children hospitalised with acute gastroenteritis and convulsions. The study was performed in Israel. It reviewed 3,573 children admitted to hospital with acute gastroenteritis, and of them 68, which is nearly 2%, developed convulsions. And so convulsions with acute gastroenteritis differed significantly according to age, with kids aged 12 to 23 months comprising nearly half of the cases. And children with convulsions and acute gastroenteritis also had a higher percentage of bacterially induced acute gastroenteritis, mainly shigellosis, than compared to the control group. So, in this paper, it's the correlation is that the bacterial infection or the infection itself might be correlated as well to the convulsion. But again, we don't know. So that's the thing.
Okay, so we're going to do it. Another question, or do you want to go back to some of the...
Well, we've got a lot of questions.
Okay.
And you spent 40 minutes on vitamins. So let's do one more question, and then we'll go back to the listener mail. Or
okay.
What are we at? This is the Q&A.
This is the Q&A.
Okay. So this is from Zola. Zola says, "Hi, doctors Mark and Matt." I assume that was just a autocorrect. After a rough run of sickness, I found your podcast on immune system, which was excellent. Thank you. I have MS and was familiar with T and B cells from reading about the DMTs. So DMTs are the disease-modifying therapeutics.
Okay.
Right? So I have MS and was familiar with T and B cells from reading about disease-modifying therapeutics, but you explained it brilliantly. To add this, I had an autologous hematopoietic stem cell transplant 2 years ago in the hope of stopping the MS in its tracks. She first asks, what are your thoughts on this? So personally...
Is there anything else in the email?
There is, but I think...
Do you want to answer this first?
We'll answer this first, and then we'll go on to the next part. So thoughts on an autologous hematopoietic stem cell transplant for MS. So there's a couple of different ways MS is treated, right, in regards to the therapeutics. So what type of therapeutics can be provided for multiple sclerosis? Firstly, what's multiple sclerosis?
Or MS. Yes,
MS.
That's right. Okay, multiple sclerosis, as the name suggests, is multiple, more than one, sclerotic plaques, scarring within the central nervous system. Okay, so what this basically means, there's regions of the central nervous system that begin to become demyelinated.
Yeah.
And
what does that mean?
Around the neurons, so as I spoke earlier, that these are the excitable cells that send information amongst each other. To send that information more effectively and quicker, they have myelin wrapped around their axon, which is the part of the cell that really sends the action potential or the impulses.
It's the coating that protects the signal.
That's right.
Maintains a nice stable signal that can be propagated down the neuron, just like a rubber coating of an electric wire for your hi-fi system.
Yes.
If that's damaged, then it's going to
get shorting,
disrupt the system.
Yeah. So what happens here is this is what we refer to as a type 4 hypersensitivity disorder, where the immune system is a cell-mediated immune response to the myelin. And what happens is particularly the T cells, so this is a type of lymphocyte that generally regulates the adaptive immune response. So this is the specific arm of your immune system. It becomes hypervigilant, particularly to myelin. And so for whatever reason, it starts to see the myelin as foreign and begins to attack it.
Yeah.
It recruits other immune cells to partake in this response, and it starts to attack the myelin. And what happens is you kind of go in these bouts of attacking and then
relapsing and remitting.
That's right, remitting. So it kind of focuses in on certain regions, attacks it. You'll start to get your symptoms associated with that region being attacked. But then another group of immune cells will come in and say, guys, hold it, relax a bit. And in that period, there is a bit of recovery. And so we kind of see these bouts, waves of symptoms. So there's a kind of probably 4 subtypes of MS, and they're on degree of severity. Some are kind of what we call the relapse in remitting, and it's kind of these long waves that can be between months to years before you see the next set of symptoms. And then as you move down, there's more severe forms.
Yeah, it becomes quite progressive.
Progressive, that's right. Now, depending on which one of those subtypes you sit would determine the treatment that the neurologist is likely to go with. With the relapse in remitting form, they may just see when you come into your relapsing phase, which is the flare-up phase, and say, let's just treat that at this point in time with immune modulators or immune suppressors and anti-inflammatories. So these are kind of like steroids and so forth. So they try to halt the immune system at that point and then let you go back into a remitting phase. But if you've got the progressive form, which is kind of just this ongoing worsening, they're more likely just to try to regulate all the symptoms that you're likely to see as a result. So a lot of the treatment or management is around trying to dampen your immune system a bit.
So wait, what are the 4? Did you actually talk about the 4?
They're just kind of subcategories. So the standard one is the relapse in remitting, and then the next one is the secondary progressive, which is the relapse in remitting, but each time it comes back, it gets worse.
Yep.
And then we have the primary progressive, which is
it's just getting worse.
It's just getting worse. And then you have, the worst of the lot, which is the progressive relapse. So it's just getting worse, but it still has those relapsing superimposed on it. And so that's probably going to be the most aggressive form. Mm-hmm. Now, depending on those subtypes would determine the treatment.
Yeah.
As I said, one of the main stay approaches to the treatment is trying to tell the immune system to relax and slow down a bit. So that can be done through pharmacological means. But another means of doing so is that they can, because you've produced antibodies and you've got immune cells that are attacking your myelin, you can actually take some of your plasma out, which is the fluid portion of your blood, filter it, and hopefully you pull out all the antibodies that are against your myelin out with it, and then you put fluid back in, and hopefully your immune system is a little less aggressive. Does that make sense? Now, in the question that was asked, it was around stem cell.
Mm-hmm. The autologous hematopoietic stem cell transplant.
Now, this particular method is used in cases of chemotherapy for leukemias, mm-hmm. which is where individuals have cancer, but cancer within their bone marrow, which then progresses out into the blood. And so a treatment for that is to essentially kill off all the bone marrow cells that produce blood and then reintroduce new blood cells, sometimes from other people, to restart the immune or the blood production. Now, in this case, what's the term used?
Autologous.
Autologous. So that means it's from the same person. Okay, so what generally would happen in this particular treatment is the body's prepared, so they're given medication to prepare the bone marrow cells for this transplant. And what that does is it pushes some of the bone marrow cells out into the blood. So now the blood is flooded with these cells. Then they're taken out. So this is the what do you call that? Pulling out phase. Not sure what the term is.
I'm not sure.
So you're taking the blood cells out, which
the extraction.
Presumably the healthier form. And then you treat with chemotherapy. So now you're blasting all the immune cells and blood cells in the body. And so then you start afresh.
Is it chemo or radiation?
That would be probably chemo, I think.
Okay.
And then you put in the ones you took out earlier back in it with the hope that this will kind of reboot the immune system with a more friendlier approach to, and not attacking your myelin. So that is the actual treatment.
Yeah.
Now, when I looked on, there's the MS Australia website, it mentions this particular treatment and it talks about studies that have involved this particular method for management, and it basically said the evidence is not conclusive yet. There's some that suggest that it has some benefit, particularly possibly with the more aggressive forms, but they haven't really established a consensus yet. So it's hard to comment on would it be something recommended or not. But that particular website, so that's the Australian MS or MS Australia website, that would be a great resource to go to check that out, because it lists all the clinical trials that have used this particular treatment and how it is possibly beneficial.
Yeah. There was a publication in JAMA Neurology, which is a very well-respected high-ranking journal in 2021, and it stated that the National Multiple, this is 2020, it stated that the National Multiple Sclerosis Society believes that AHSCT, which is autologous hematopoietic stem cell transplantation, may be a useful treatment option for people with relapsing multiple sclerosis who demonstrate substantial breakthrough disease activity, so new inflammatory central immune system lesions or clinical relapses, despite treatment with high efficacy DMTs, which was mentioned earlier, disease-modifying therapies, or have contraindications to high efficacy disease-modifying therapies. The best candidates are likely people younger than 50 with shorter durations of disease, so less than 10 years. The procedure should only be performed at centres with substantial experience and expertise. Ideally, recipients of the procedure should be entered into a single database, and further research is needed to establish ideal cell mobilisation and immune conditioning regimes. So similar to what you said, they're basically highlighting that there seems to be some benefit as a treatment option. But then an editorial published, again in JAMA Neurology, last year in May, asked the question, is autologous hematopoietic stem cell transplant better than high-efficacy DMTs, disease-modifying therapies, for relapsing multiple sclerosis? And the authors were referring to a recent study by Kalinchik and colleagues. And what they stated is that the current study, referring to the Kalinchik study, which was a clinical trial, highlights that AHSCT may have advantages over some but not all existing DMTs used for the treatment of MS. So again, at the end of it all, you ask us, what are our thoughts? I have to say, Matt and I rarely have thoughts, but what we can do is this, and look at the available evidence and simply regurgitate what the experts in the field are stating. So
and maybe simplify what that means.
Yeah. So, we don't have any personal perspectives on this. However, this is what has been stated from what we've been able to identify. Now, the second part of the question.
Can I just say one thing?
Yes.
There was also a recent study where they looked in the origins of MS. Did you see that recently?
Yeah.
And they've associated with a particular ethnic race that I don't necessarily think still exists, but it was probably the the Eastern Steppe region. So it's kind of Russia, Eurasia maybe. And they found that a certain clustering of people, which has now probably populated a lot of North Europe, who did a lot of farming, so agricultural activity with a lot of animals, they found that they had a particular genetic predisposition for a type of immunity, and I think this is with the HLA antigen, which is associated, I think, with the presentation of antigens on presenting cells. So that, the MHC2, I think, receptor, and they found that they were more effective with certain pathogens, which would have been beneficial. So that this is what I never saw this study. The evolutionists proposed that they would have had benefit because they were with so many animals with zoonotic infections to protect them against that. But because our lifestyle has changed somewhat.
So what you're saying, they're protected from MS? Or
no, they were protected against certain infections.
So what's the link to MS?
So now, because we don't live that type of lifestyle, we still have that kind of vigilant immune system.
Yeah.
But in a lot of MS, so when you look at risk factors, Northern European is one, but also a triggering event, which is
that's what I read.
The virus.
Epstein-Barr virus.
Right. And so what it's suggesting is instead of the immune system kind of focusing on ongoing infections, it's now been triggered by this virus, which has now pushed it into a less tolerant to self subtype, which is now attacking the myelin.
Yeah, I did. Yeah. I mean, there is a paper here that was published last year in Nature, which is a very good paper. So Nature Reviews Neurology, titled Epstein-Barr Virus as a Leading Cause of Multiple Sclerosis, Mechanisms and Implications. And the study states that infection with Epstein-Barr virus increases the risk more than 30-fold, indicating that Epstein-Barr virus is a leading cause of MS. There you go. So, and Epstein-Barr is mononucleosis, right?
Yeah, I think so.
Like, is that glandular fever?
No, I don't think that.
It's not glandular fever?
But I'm not exactly sure.
Okay. Anyway, Epstein-Barr virus. So, Zola, there's a second part to your question, so we're not going to ignore that. You asked in the second part of your question, if I can find it, right here, you also asked that you're 2 years post-transplant and don't really understand why you have not been revaccinated yet with all your childhood vaccines, which I can understand why you think that, because you've basically had your immune system reset. Your question is, should I run titer tests first to see if I need them? Finally, do you know if there's anything I can do that will stop me getting sick all the time other than the obvious? With my MS, it just floors me, and I'm a working mum of a 5-year-old. Thanks so much in advance, Zola. Look, without MS, working and having a 5-year-old is exhausting, so I can't even imagine what it would be like with MS.
That's right.
Again, we can't provide you with any advice, specific advice at least. But when it comes to vaccinations, Matt, what are your thoughts in regards to what does the evidence show in regards to vaccinations and people with immune?
So for a vaccine to be effective, we've probably seen and we've heard this spoken to so much through the pandemic, should I say?
Pandemic. Yeah, I hate it.
Poor Derek.
I knew Derek led the whole thing.
So what needs to happen is you need to have the response to the antigen, and that's a B cell response with the antibody, but you also need to have selective T cells that are coordinating that response. And so if you were to lose the antibodies that were produced, the B cells that it originated from and the T cells that coordinated by resetting your immune system, it's going to be difficult for you to have that ongoing immunity. So that's a difficult one to comment on but saying that serology is generally a fairly common method to see whether you are likely to have immunity to that particular.
And that's the running the titer test.
That's right.
It's to measure your existing circulating antibodies,
I mean,
which is something that's done to identify
it's very
whether
commonly
you've got a degree of immunity available.
So for our students, for instance, if before they can go out in clinical placement, they have to have all their specific vaccines, but they have to also demonstrate that they've got immunity to that. So they'd have to do serum tests for, let's say, hepatitis B to show that they are indeed likely to be immune for it. We have a colleague who's got MS, and she regularly goes through her ongoing vaccines. From my understanding, because a lot of the time they will be immune suppressed through the medication, there is concern with some types of vaccine, particularly the live vaccines, because technically the vaccine is still alive. It's weakened, but it's alive. So if you have a weakened immune system, there is, at least theoretically, the possibility that you could be infected with it, but that would be a low risk. So there might be that consideration with the live attenuated vaccines. But generally speaking, when you look at the chain of infection, which is how infectious agents move through a population, let's say, when we look at susceptible hosts, which are individuals like infants, aged individuals, or immune suppressed individuals, vaccine is the recommended way of breaking the chain in that region because you are making them less susceptible. So prepare, for an example, individuals within an aged care facility, they would be given annual flu vaccines, pneumonia vaccines, because they are at risk, higher risk for those particular infections, as would a person who is immune suppressed, like people who are being treated with MS.
So to determine whether you need to get these vaccines, go see your primary healthcare physician, have a chat with your GP, with your doctor, and go through the conversation. Ask them exactly this: what vaccines do you need? What can you have? What can't you have? And ask about running a serum test to have a look and see whether you still have some degree of immunity for any of the vaccines that you previously had. So thank you, Zola. I appreciate that. Next, let's go through
back to listener mail.
Listener mail. So what do we got? We heard from Kristen. We've got Al Abdal. So Al Abdal said, following some courses online, dear Dr. Matt and Dr. Mike, to be honest, I watched some of your biology courses on YouTube and they're shit. Oh, no, sorry. I watched some of your biology courses on YouTube and I love your methods of teaching. Therefore, can I please participate like a student at your school and have also some tests online? I was a teacher of the science of life in my country, Iraq, but your presentation is great. I'm looking forward to hear your reply. Best regards. Hi, Al Abdal. When it comes to providing online tests, that's just not something we are able to do at the moment, mainly because of time. Would love to be able to do it.
That's right.
Once we create our online courses, which we talk about all the time, but have yet to finish them, we've started but have not finished them, there will be tests available associated with those courses and you'll be able to access them online. But once we've made them, Al Abdal will be able to let you know where you can access them.
Which is likely to be in the resource section, right?
Yeah.
Yeah, so quiz banks and stuff.
Yeah.
So that's potential for future.
Maddie?
Leah?
Are we there?
Yeah, right? You missed one.
Did I?
Yeah.
Oh, my apologies. Yes, go on.
So this one's from Leah.
Yeah.
Subject, from the US.
Oh, that's United States, by the way, Matt. That's the United States.
Hey, guys. I'm currently listening to the overview of the endocrine system. I zoomed in too much. I love that you guys always go back and forth with different types of information. Hopefully, after listening to the overview, I'll be able to pass my exam. Smiley face.
Good.
I am from a small town in Ohio.
Awesome. Have you ever been to Ohio?
What's that? Small town girl.
Yeah.
Living in a lonely world.
Living in a lonely world. Yeah, that's right. On a midnight train going anywhere.
That's a good song, that one.
It is. It's got nothing to do with Ohio, though. So thank you so much, Lee. Lee or Leah? What do you think? Lee?
Leah.
Leah?
Yeah.
Lee? Could be Lee. Anyway, Lee or Leah, thank you so much. We truly do hope that you pass your exams. I've never been to Ohio. I've been to the States multiple times. Where is it? Do you know where it is? Is it?
I've been there.
Where is it? In the middle?
No, it's more towards the north.
I've been to Nebraska. That's like smack in the middle.
That's right in the middle. Yeah, I haven't been in Nebraska.
Okay.
Ohio, been to Columbus, Ohio.
Oh, yeah.
I went to...
Where is it? North, did you say?
It's considered... I'm not sure if this is a bad term, but it's considered the Rust Belt of America.
The Rust Belt.
Which was where I think that all of the automotive industry was. So like Michigan and Detroit and...
Ohio's near there.
Yeah.
So it would be cold in winter.
Cold, I would imagine.
So right now...
I don't think it was... it's kind of there in spring, I think.
So it'd be nice there right now. No, it'll be cold. It'll be still... Yeah, it'll be freezing. Spring, yeah.
Probably the similar time I was there, actually.
What's the temperature right now, Leah? We'll figure that one out. Thank you for the email.
And all the best. Let us know how you go with your studies.
Yes, please do. We've got a question from Safe. The subject is effects of castration on the male body. That's interesting. Hi, I'm curious about how surgically removing the testicles would affect the male body. How would it affect testosterone in the body? What are the negative effects on the body? I heard it affects cardiovascular health. How would it affect sexual attraction? This would lead a person to needing pharmaceuticals for the rest of their life to live properly, right? That's a lot of questions. Function of testes for hormones. Why would they be removed? Effect on body. I'm not sure what those terms are below, but Safe, thank you for the email. I'm not sure about the context of the question and why you're asking this, but that's fine. So the medical term we use is bilateral orchiectomy.
So two sides.
Yeah. Get rid of the orchids.
Orchids.
Yeah.
Yeah, get rid of the orchids. Ectomy. That's to get rid of.
That's right.
Orchids.
Yeah. Which is the reproductive part of the plant.
Okay.
But in this case, we're the plant. So bilateral orchiectomy. Now, this can happen through gender-affirming surgery, trauma. I was reading a paper.
Both sides?
Well,
both testes.
There is a case study, I can't remember the name of it, of bilateral orchiectomy due to trauma, and they had photos.
Oh.
Boy, not the best thing to look at. I was thinking about putting it up on the YouTube channel.
Was it like a bicycle accident?
They didn't say what caused it. They just said direct trauma, and you could tell it was direct trauma. Anyway, they had to get rid of the testes, or it can happen due to cancer. So not necessarily testicular cancer, in which you can have a testes removed. Very rarely is it the two, but it can happen because of prostate cancer and the effects of testosterone there. So your question is, what happens? Well, your testosterone levels significantly go down, but this happens with hypogonadism, for example, which isn't uncommon, where the testosterone levels can be low. And we know that low testosterone levels are associated with lower bone density, reduced libido, alterations in mood, among other things. So what you'd need to do is take testosterone replacement therapy.
Yeah.
And that's basically it.
I guess it would depend on the age of the individual when this was done.
Very true.
Because with, like you said, with testicular cancer, which is probably more likely to happen to younger individuals.
Yeah, under 35 generally.
Then because they've still got a lot of growing to do and a lot of life to live, it's likely that the complete absence of testosterone all of a sudden would then need to be replaced.
Mm-hmm.
Whereas with prostate cancer, specifically the role of DHT, so that's dihydrotestosterone, on the growth of the prostate cancer cells is like
negative. It's not good.
It's negative in the sense it makes it grow faster. Mm-hmm. So by removing the testes, there is that benefit of not having the testosterone to grow the cancer as rapidly.
So sometimes they do the orchiectomy to reduce the testosterone.
Yeah. And they do similar things in the female when it comes to breast or other reproductive cancers with the removal of the ovaries. And
give the individual replacement therapy.
Yeah. So
look,
it may be different with an individual with prostate cancer because they're likely to be later in life, like 60s plus, so that they may not need the type of replacement as you would if you were a teenager or a 20-year-old.
Yeah.
There's also the castration that can be done medically as well, or is that the correct term? Opposed to chemically, should I say?
Chemical
castration versus doing it surgically.
Yeah,
I think the thing with the testicular cancer, the difficulty with having the tumor in the testicle. That's the incorrect term, isn't it? Testicle?
Well, testicle is more colloquial.
Yeah.
Testis.
Is that the drainage of the testy.
Yeah.
And they can't kind of go in and just pull out the tumour.
Yeah.
Because of the risk of seeding the tumour into the lymph.
Yeah.
So that's generally why they have to take the whole testy out.
Yeah.
Whereas, let's say if that was, I don't know, a breast tissue, you could take a lobectomy and remove a portion, and that would probably be quite fine. But that's the consideration with a testicular cancer.
Yeah, that's right. So,
did you answer all the side effects?
Well, I mean, the side effects of having low testosterone, like I said, is reduced bone density, lowered libido, changes in mood. I mean, there's a range of effects, and it's too hard to really talk about the specifics of them because it all depends on the level. The testes aren't the only place that produces testosterone, but obviously they are the most significant for males. So a replacement therapy would be what's commonly performed, or the intervention that's performed after this. So, Matt, we've got one from Emma.
You want to read it?
Yeah.
Okay. It's on your screen, that's all.
Oh, okay.
Okay, so this is from Emma.
I can read it if you want. It's one sentence.
I'll do it.
Okay.
So this is from Emma, subject matter PD. So that could be Parkinson's disease.
Or professional development. Or peritoneal dialysis, which is the question.
So the message is, can you please explain how peritoneal dialysis works? Thank you so much.
No problem, Emma. Thanks for the hello and all the other things. Oh, no, that's right. You only just asked the question. Is this because is this an exam thing? Are you wanting us to answer, is this an assignment? Anyway, regardless, I'll tell you what peritoneal dialysis is. It's very cool. Generally speaking, your kidneys filter your blood, and it does it all the time. It filters 120 mils of your blood every minute, called the glomerular filtration rate. It does it by pushing it through a multitude of membranes in the kidneys, and it does it very efficiently. What it's filtering is metabolic byproducts, toxins, waste, anything that shouldn't be
a wet bed
there. We're not going through that again. You can listen to that podcast if you want to hear Matt's mnemonic of a wet bed, which isn't as good as mine. So that's the role of the kidney, or one of the roles of the kidneys. However, some people who have end-stage kidney disease and aren't getting a kidney transplant.
I wonder if it's also used in acute kidney failure as well, or kidney injury, where they just have to take the pressure off the kidney, or whether it's more hemodialysis.
Yeah.
Be interesting. Well, anyway, keep going.
Okay, so regardless.
More chronic.
Yes, definitely more chronic. End-stage kidney disease. The kidneys aren't working, and so your blood needs to be filtered, and it's very important. So we need to undergo a process called dialysis, which filters the blood. Now, there's two major types of dialysis. There's hemodialysis and there's peritoneal dialysis. The hemodialysis, you're hooked up to a machine. You've got a tube that takes the blood out of your body, runs it through a synthetic membrane in a machine that works as your kidneys and filters out the stuff that shouldn't be there, and then just brings the blood back into your body, right? That's hemodialysis. Peritoneal dialysis, on the other hand, is different because it passes, basically, the dialysis membrane that it uses is your peritoneal membrane.
And what's that?
In your peritoneal cavity. So inside your abdomen, you've got membranes that line your abdomen that hold the organs in, called the peritoneal membranes, and they're highly vascularized. And so if you can picture this, there's no tube that sucks your blood in or out like the hemodialysis. It works by trying to suck the blood through the highly vascularized peritoneal cavity from your body into the empty cavity. It's basically trying to suck the fluid in and use the peritoneal cavity now as basically a storage facility for the waste products.
Yeah.
The question is, how do we suck the waste through the peritoneal cavity? And so a nephrologist, so an expert of renal disease, will need to introduce through a bag a highly osmotically powerful agent or fluid that sits in your peritoneal cavity, and the osmotic gradient will then pull the fluid, water, substances into the peritoneal cavity, and then you drain that fluid out of the body. And that's peritoneal dialysis. The question is, why would somebody need to do that as opposed to hemodialysis? It's just, often it's really just choice.
Yeah, convenience.
Because you can do it at home.
Yeah.
Right? So hemodialysis, we're in the machine. You got to go in. You got to go into a place. You got to do it multiple times. It's not like this quick 5-minute thing once a week. It's at least every day, sometimes multiple times a day for multiple hours. That's which indicates how efficient your kidneys are.
Yeah.
Right?
So there's a couple of methods with the peritoneal dialysis. There's one that you can kind of do it in kind of periods of the day, and there's one that's overnight usually. So you hook yourself up. So there's been for this to work, a port is put in through your anterior abdominal wall, so through the muscles of the anterior abdominal wall, and then put into the spaces kind of where the intestines would sit. And this is your peritoneal cavity. And then when you go to bed at night, you would connect your bag to that. And
that's the osmotic fluid bag, yeah.
And it would coordinate automatically the introduction of the fluid into your abdomen. So that could be from 2 to 3 litres. And as Mike said, it's hyperosmotic, so it's very high levels of glucose, usually as the agent, amongst other things, that would cause the change or the osmotic shift between what's in your blood to go into the peritoneal space and coordinate the removal of toxins and metabolic byproducts that you don't want to be building up in your blood.
Yeah.
And then by the time you wake up, it's kind of done the cycles.
Yeah.
So it's done a fill up, slosh around, and then a removal.
Yeah.
Whereas the other method, which is the ambulatory method, is kind of done in shorter periods. So you'd have to maybe do that a couple of times in the day.
Yeah.
But in any case, the peritoneal is much more convenient than a hemodialysis. As Mike said, you generally have to go into a dialysis lab and spend quite a lot of time there to have that process completed.
That's right. That's right. So hopefully that did help, Emma. Best of luck with your assessment item. All right, question. We got a comment from Peter from Kansas. The subject is Australia
versus... Have you got a Kansas song?
Korea. Walking in Kansas. Well, what about The Wizard of Oz? Is there a song about Kansas?
What's the first one?
We're off to see the wonderful Wizard of Oz. No, that's not the first one. It doesn't matter.
Is that appropriate for a 3-year-old? Should I show Zarina that movie yet?
No, it's not appropriate for my 6-year-old.
Okay.
She freaked out. She liked it. It's fun. It's quite frightening. But definitely not for a 3-year-old.
Okay, all right.
However, I've shown my 3-year-old, but he
couldn't care less.
Was not asked. He did not care. All right. Peter from Kansas. Subject, Australia versus Korea. This isn't a war reference, is it? First of all, thank you for your content. I listen to your podcast on my way to school, and most of the time what I remember is all the ways Dr. Mike makes fun of Dr. Matt. Thank you, Peter. That is correct, because Matt is what we call in the medical industry a loser. Secondly, I'm sure you saw Sun's free kick in the extra time in the quarterfinals of the Asian Cup. We got our revenge. I didn't watch it. Did you watch it?
No.
I didn't watch it.
Soccer's not really my bag.
What is?
Rugby.
Oh.
I prefer rugby.
Really? Which one?
Union.
Not league?
No.
Oh,
look, I'll watch I'll watch league.
You like to wear a collar when you get your head pounded in, don't you?
I'll watch league, but I prefer Union.
That's the only difference is one wears a collar, one doesn't.
Cricket?
No, thanks.
Moving on.
Thank you, Peter. Yes, I'm going to continue to tease Matt. And so because...
Usually we get emails that people complain about your teasing to me.
Yeah, but Peter loves it.
Yes.
Peter said, he didn't say it, but I'm reading between the lines. He's saying keep doing it.
Keep going with it.
Keep doing it because Matt needs to...
be brought down a couple of levels.
Yeah, he does, yeah.
All right, this one's from Sharon, and the subject here is downloaded into MP3.
Oh.
Hi, I'm a new student learning introductory to nursing.
Yep.
My sister, a paramedic, and lives your podcast.
I think lives on.
Yeah,
lives on your podcast.
And has downloaded it for me to listen and learn.
Nice.
Loving your shows. My question is, how do I download the MP3 so I can have it on the go?
Okay, Sharon. I don't think you can unless you've got a program that can take podcasts and do it. But our podcast is available
on all podcast platforms.
Yeah. So you can do it on Spotify, and you can do it on iTunes, and you can do it on iHeartRadio, and you can do it on
iHeartRadio,
Google. Yeah. It's everywhere. So I reckon you could.
But you can download it onto the platform, so you can listen later without internet, right?
Yes. So if that's the problem, is if the problem is you want to listen to it but you don't have available Wi-Fi or internet, you can download it while you are on Wi-Fi and internet. You just press the down arrow button and then you've got us there for life. Thank you, Sharon. Question?
Good luck with your studies.
Back to question?
Yes.
All right. This is from Johnny Lynn. Johnny Lynn I hope I'm pronouncing your name properly, Johnny Lynn. AMP, that's the subject, which stands for Anatomy and Physiology, I hope, because that's all I know. Message, I'm really struggling to understand the endocrine system and the cardiovascular system. What videos do you recommend watching that will help give an AMP overview of each topic?
Let me guess, yours?
100%. You have several videos that are smaller clips. I was hoping to watch more of a lecture type video similar to the neurotransmitters video. Thank you very much, Ray. Hi, Ray.
So did you do a full-length neurotransmitter video?
No, I thought it was only 20-odd minutes, but I've got an overview of the endocrine system, which I think's got a couple million views, which goes from top to toe of all the glands and all the hormones that are produced and their function. I think that is a great, like if you're having difficulties understanding the endocrine system, I think that video will be the best go-to. It probably gives you most of what you need to know as for an introduction. Otherwise, when it comes to cardiovascular system, I've got, I reckon, at least a dozen videos on the cardiovascular system. I'll probably start with an overview of the anatomy, which I've got there.
Have you got any of those videos that you made for your students in the pandemic where you actually had the...
Live, yeah, they're there.
Okay.
Or if you go into the live tab, you'll see live seminars I recorded for my students, which are on all these different topics. They were fun. So, Ray, give those a shot. If they're not helpful, send us another email with some specifics and I'll make a video.
And we also have two podcasts, one on the endocrine system and one on the cardiovascular system.
That's true. They'll help too. Matt, we've got an email here.
You can read this one.
From Ray again? I think
the last one. Yeah, that Ray should be further down.
Okay, John Aline, not Ray. My apologies. Now we've got one from Ray.
That's Ray now.
Do you want to read it?
No, you go.
Okay, subject, antibodies. Message. Hi, I'm struggling to find an answer to a question that is making my brain itch. Why is it that being IgA, which is immunoglobulin A, which are antibodies, deficient, why is it that being IgA deficient can give a false negative TTG in celiac patients? Okay, a couple of things to define here shortly. I've noticed in our cohort of immunotherapy patients, a couple with colitis who have in fact been ultimately diagnosed with celiac disease, but initially TTG negative. However, their IgA has been low. I found a couple of academic papers which say this is a research phenomenon, seems evidence, but cannot find why. All I can think is that IgA somehow has some sort of protein detector which is deficient, can then mean there are fewer TTG detectors, therefore giving a false negative celiac result. But this feels like a poor conclusion. Thanks. Love your YouTubes and podcasts and pass on your education to all my colleagues. Thanks a lot, Ray. Ray, thank you so much. And the answer is easy, Ray. But before we answer it...
Can I do it hard? Can I answer it hardly, not easily?
Yes, but let's just we'll to begin with.
I didn't realise what you meant there.
Well, okay. I'm going to ask you questions. All right. What's celiac disease?
Celiac disease, I don't think you would say it. Well, is it an autoimmune disease? Kind of not. It's probably like a combination of hypersensitivity, but it has an autoimmune component to it. But what you're reacting to is the
protein
seed product of
gluten, right?
Yeah, so gluten.
Yeah.
So like wheat, barley, rye.
Yeah.
The seed in the seed.
And that will have anatomical,
protein.
physiological effects on the body. Now, so that's the first thing. Second thing is that the gold standard of celiac disease diagnosis tends to be an intestinal biopsy, right? That shows flat mucosa.
Yeah, instead of the big waves or the big fingertips.
Yeah, not cilia. Villi or microvilli. All right, so the biopsy is the gold standard, but they're now starting to use antibody markers to help identify individuals who might be unsuspecting or in risk groups. So we're now starting to use these antibody markers. Now, TTG stands for tissue transglutaminase.
Yes.
Tissue transglutaminase is an enzyme found in the tissues of the body, like the small intestines. And regarding celiac disease, tissue transglutaminase, TTG, plays a key role in the autoimmune response that triggers once gluten is ingested and somebody is susceptible, TTG is involved. So once the exposure to gluten leads to the immune response, it then damages the lining of the intestines, which we alluded to before. Tissue transglutaminase is a key autoantigen involved in the process, right? So the immune system will produce antibodies, specifically anti-tissue transglutaminase, called anti-TTG antibodies, which target transglutaminase in the small intestines. And so you can detect these anti-TTG or the TTG antibodies in the blood as a marker as part of diagnosis for celiac disease.
Yeah.
Just that's for everybody and yourself who didn't understand, right? Now, the thing is, anti-TTG is an antibody. It's an IgA antibody.
Yep.
And the question here is, why in individuals who have deficient IgA would you get false negatives of TTG, meaning you measure TTG and it's low in celiac disease? And the answer is because TTG is IgA. So if you've got someone who is already low in IgA, the TTG will be low as well because it also is IgA. And that's it. Now, did I take the wind out of your sails?
No, not really. But I think there's also a phenomena where if you have celiac disease...
So every time you say phenomena, I do that.
Okay. Not sure why.
Say it.
Phenomena? So with individuals with celiac disease, there is an unknown phenomena that they will develop IgA deficiency.
Oh.
So I'm not sure if she was meaning in that direction or the direction that you read from.
Well, I thought because it says here, she said that I've noticed in our cohort of immunotherapy patients. So my assumption was maybe these individuals who are receiving immunotherapy, maybe for cancer or whatever it might be, or something else, and it's lowered their IgA.
So a couple of things just with IgA. This is what I was going to speak to. So
I'll sit back and relax.
We have two forms of lymphocytes.
Speak for yourself.
We have Bs and Ts.
Yeah.
Now, the B cells, the reason why they're named
Barton
B
cells and Todorovic cells. Makes sense.
We should have used this earlier. So why are they named B cells?
Well, if they're named after you, they're pathetic. They don't do much.
That doesn't make sense.
They sit back and relax.
They're very useful, Michael.
They're red?
With staining.
Okay. So that's all hair colour. I knew it. Anyway, okay, what are B cells? B cells, B lymphocytes, they can produce plasma cells.
No, why are they called B? That's what I'm saying.
Oh, because they produce and mature in the bone marrow.
Very good.
Oh, thank you.
So
for the clarification.
They produced and they mature in the bone marrow.
Yeah, that's literally what I said.
Now, what happens then?
Yes.
They move to certain
lymph cells.
What do you call it?
Lymphatic tissue.
Secondary lymphatic, or is it primary?
Well, it can be both. Primary lymphatic is going to be things like the spleen.
Yeah, so it's primary then. So they move to the primary. So they move to places like the spleen, lymph nodes, and in this case is where it's important.
Here we go.
Malt.
Oh,
not the sugar.
Like a malt shake.
No. Mucosa-associated lymphoidal tissue.
My favourite type of shake.
Okay. Now, what happens here is, I guess they're already matured, but they're naive, right? correct?
Yeah, okay, yes. So it's a very good question. This is something that I struggled with for a long time. They have matured, but they have not been exposed. So in a way, they are still immature.
Yeah. So now we're going to focus on the molt because this is the mucosa-associated lymphatic tissue because the gut is mucosa.
Yeah.
Okay. Now, interestingly, with the molt tissue, that is specifically IgA antibodies.
Yeah.
So when we look at antibody, there's different classes, and then really all you need to know by the classes is the constant region. The variable region, which is the Y part. So if you think of an antibody like the letter Y, is that how you describe it?
Yeah.
The Y, the top part, the two arms, is the variable region, which is going to be specific to the antigen.
Yeah.
So in this case, it would be specific to gluten.
Mm-hmm.
Okay, but the bottom part, the body of the Y is the constant region.
Yep.
But when they go to their tissue to become less naive, this is where they go through class shifting. So they can move from an IgD or an IgM to an IgA. Now, this is where I found it interesting.
Yep.
If you can get an IgA antibody specific within your molt mucosa, you can effectively become immune because what it will end up doing is it will put the antibody out into the mucous membrane, so the apical side, where like the mucosa is. So that then allows the immune system to be resistant to the potential oncoming microorganisms. So I would imagine that this is the, what's it called? When they're striving for the holy grail.
Yeah.
For vaccines when you're trying to get a vaccine for a respiratory condition.
Yeah.
Because if you can get an IgA vaccine, you can basically prevent the virus even infecting you because the antibody's already out on the surface of the mucosa. Does that make sense?
Sort of.
So that's where those antibodies work. But what happens with the IgA deficiencies is to go through the process of that making it less naive, it has to go from the naive B cell to be presented with the antigen to then have a relationship with a T cell to then make it into a plasma cell. And that relationship is through cytokines, right? So there's a communication with the right T cell, the cytokines, the B cell to now become a plasma cell. And so all these things have to be in place to then have adequate amount of antibodies. But if you were to have some kind of defect in this process, so if you were to have an abnormality in your B cell or problems with your T helper cells or a different type of cytokine reaction, because that's the communication, or the plasma cells are getting killed off, then effectively you're going to become deficient in IgA antibodies. So when we go to celiac disease, that's where I read it. I read it in a different direction. I think the way you read it, which is obviously correct, that's what was stated in the email. But
when's the interesting part coming?
Well, the idea for me was how does celiac disease lead to an IgA deficiency? That's what I thought.
Oh, no, okay. Well, it's not what I thought. Yeah. Okay, but look, Ray, let us know who is interpreting your email. I think since my answer is more clear-cut, I believe it's me.
So
I feel like Matt's circuitously working round and round, and I'm not sure what his point is.
Well, my point is, for the celiac disease,
yes,
you have to do almost the same thing as what I said to make the IgA less naive. You have to involve a B cell, a T cell, and cytokines, and all of those are impacted heavily in celiac disease.
But why would that result in the reduction of IgA?
Yeah, I don't know. Because that was the part that I wasn't sure about.
Okay.
But it is a known phenomena.
Thank you. All right, let's do some questions. Some listener mail, I should say. This is by Christine and Motaz, Ayesh, and Sarah. Well,
so I actually combined 3 emails in one here.
Oh, okay.
Because they're either classmates or it was maybe just the start of semester and everyone's doing cell pathophysiology or pathology.
Okay.
So basically, they've all asked us if we can do more things from Robbins. And
so this is okay. Robbins General Pathology.
It's a well-known textbook.
It is. I've got it sitting in my office.
As a doorstop.
Yes. It's sitting there. Do we have it up on the shelf up here? No, I can't see it, but it's definitely in my office. All right. Christine, Motazayesh, and Sarah have all stated in one way or another, it would be great if you could cover Robbins general and systemic pathology and pathophysiology topics.
We've done cell injury and we've done inflammation. So we've already ticked those off.
Yeah.
Let us know if there's any specific...
Yeah, give us some other stuff. I'm happy to do more path, and so is Matt.
I'm happy to do IgA deficiency.
No, I don't think anyone wants that. Here's one from Kelly.
Is this your wife?
No, it's not my wife. Let's see, because she would never put a heart emoji into an email. IBD course. Hi, guys. IBD and endoscopy nurse here. Would love a course that contains information about pathophysiology of the disease and the associated complications and emergency presentations. So firstly, what's IBD, Matt? It's inflammatory bowel disease, yeah? Not irritable.
That's IBS.
That's right, because it's not a disease, it's a syndrome. Believe me. Also, the treatments and medications like MTX, immunomodulators, steroids, 5-ASAs, biologics, and the reasons for changes in blood pathology results. Example, iron changes, vitamin D, albumin levels. I feel like it's an area that's so interesting, really difficult to find educational material that explains these things in an easy way to understand. Or maybe I just love the way you guys teach. Firstly, thank you, Kelly. You are kinder than my wife, I must admit, giving us compliments. I do like the way I teach. I think the good thing about having Matt here is he tests me, and so
do I?
I'm forced.
Your patience.
My patience, and I'm forced to figure out how to explain things in a way that a 3-year-old would understand, and that's just so Matt can go
grasp it.
So when I explain it that way, Matt goes, just dumb it down a little bit more, and then I explain it again, and he's like, now I get it. And so I figured out the best way to explain things simply because I work with him. Now, to do a course on inflammatory bowel disease would be great. And it's not out of the cards or off the cards or even in the cards or on the cards maybe. But it's got something to do with cards. No, now I'm confused. I think this is a great idea to do, inflammatory bowel disease. We just need to figure out the best way to do it. It is in our area of expertise. We have to be clear about that. But we could do a podcast episode on it, and maybe off the back of that, we could do a course.
That's a good idea. Maybe a podcast to start with.
Yeah, do a podcast to start with, because when we do the podcast, we tend to jump into the literature as heavily as we can with the limited time that we have. But this sounds great, Kelly.
And if we were to do a podcast, let us know exactly what you'd like us to cover in it.
Oh, yeah.
I mean, you have pointed out a whole lot of stuff there.
Well, it doesn't have to be she. Kelly might be a he. So I know a male Kelly, so I do apologise.
I do as well.
All right. Question. No. Comment, I suppose.
Yeah.
You do this one. Only because I want to see Matt try and pronounce the name.
M. Joshua.
Mugambege Joshua. Please send us another email and tell me if Mugambege Joshua. I think I've got that right. Mugambege. Please tell me. And if not, I do apologise. The subject is appreciation. I'm grateful for your podcast. We are grateful for you. That's me saying that to you, Mugambege. It is a game changer for me in my nursing career. I listen to you guys every day, especially now I'm in my second semester. I love it. Keep doing what you're doing. Lots of loves. Greetings from Uganda. Have you ever been to Africa?
Every day is pretty good, isn't it?
What does that mean? I listen to you guys every day. Yeah. Yes, that's awesome. Because I don't even want to listen to me every day, let alone Matt. I think, and we've got enough episodes to listen to every day probably now. But have you ever been to Africa?
I have.
Have you been to Uganda?
I haven't.
Okay. I'd like to go to Uganda. A friend of mine went to Uganda recently. Said it was amazing. Amazing. So thank you so much. Truly, we really appreciate it.
One more?
Let's do the final question.
Okay.
Final question is by Regan. Regan says, the subject, the brain. Message, hi guys, love your shows. plural, because we've got heaps. Currently doing Bachelors of Science in Psychology, or is that just a bachelor's? Bachelors of Science in Psychology? I'm going to say Bachelors in Psychology. And in the episode about the brain, you mentioned having done a paper on why some people are left-handed. We did too. I'd love to read it. Where can I find it, please? Thanks so much to both of you for all your time and hard work putting these shows together. They are invaluable. Regan from New Zealand. Awesome. Okay, Regan, the paper that we wrote isn't a... We wrote the paper.
Oh, did we?
We wrote a paper.
Oh, I thought she said refer to a paper.
No, she said we mentioned that we wrote a paper on people left-handed.
Okay. I think the writing was just a conversation piece.
Yeah, well, I was just going to say, so the paper we wrote was for the conversation. So we took the available evidence within the literature and we spoke about why some people are left-handed versus right-handed. And we had a great time. So if you want to find that paper, you can just go onto Google, type in the conversation, left-handed, and our paper will come up. And so we asked the question, firstly we spoke about what it means to be left-handed, why we prefer one hand over another. So why aren't we ambidextrous? Why don't we write with both hands, throw a ball with both hands and so forth?
Some people do.
Some people do, and they are ambidextrous, but it's not something that we tend to do as a species. And to take a long, complex answer and make it easy, it's simply because the brain wants to be super efficient and it doesn't want to train two limbs or two sides of itself to be crazy efficient because it doesn't have the energy all the time. So
but in theory, you could do it, right?
Of course.
Yeah.
Definitely. But yes, go to the conversation.
So what do you think is the basis for that? Is it just the wiring? So again, my 9-month-old, she's definitely preferencing her left hand.
Yeah, my daughter's left-handed.
And so do you think that's just that's just wiring?
Yes.
At an early stage.
We can tell by 2 years of age. Well, parents can tell by 2 years of age what hand their kids are, but scientists can predict it even before they're born.
Wow.
So they can, by measuring the arm movements of the bub while inside of mum, in utero, they can, with pretty high accuracy, determine whether a child's going to be left or right handed.
And do you know the basis of it?
Well, there's a strong genetic component,
which
is associated strongly with
hemispheres.
Yes.
Orientation.
Hemispheric predominance. Now, saying that, it doesn't mean some people are more left hemisphere compared to right hemisphere. It's just where the handedness sits is either left hemispheric or right. But read the paper. We go through all that. It was published a couple of years ago, 2021. I think it's not bad. And so that's the final question, but we do have a few more statements.
So this is from Damon.
Yeah.
And this subject is podcast suggestion.
Okay.
Hi there. I'm a regular listener of your podcast. I find it very helpful for consolidating my knowledge, so thank you for making it. Smiley face. I just had a thought. It would be super cool if you invited Dr. Glockenflecken to be a guest on your podcast.
Nice.
Can you organise that, Mike?
Yeah, I can contact him. Dr. Glockenflecken is an ophthalmologist in the US who came to fame through Twitter and creating these short little videos of what it's like to be in the medical industry. He also suffered a heart attack.
It's like parody, right?
It's parody, definitely parody. It's very funny.
But there's some truth to it.
Oh, yeah. He's a stand-up comedian. He has his own podcast. Yeah.
Oh, does he?
Yeah, with his wife.
Because she sometimes plays a role.
Does she?
Yeah.
Okay. So he's got a monster YouTube channel now and TikTok and all that.
And he plays all different characters. So he's
very funny.
He has wigs and big glasses and all,
He plays the neurologist. He plays the nephrologist. He plays the pediatrician. So I think we should get him on.
I remember a funny post he did.
I'll pop him an email.
Because he wears a wig for
I remember that.
neurologist.
Yeah.
And he said he had an electrician, and there was a recording tripod in his room.
Was it a tripod, a wig, and I think he said something. There's some other piece of clothing that he just thought, oh God, here we go.
I've got to sell my house.
That's right. So thank you, Joseph. I will contact him. I think that's a great idea. No, that was Damon. Sorry, Damon. That was from Damon. This is from Joseph. Differences in anatomy between pediatrics and adults and the stages of development. You want to read this one?
I think that's an important one that we need to do.
Read it.
Okay. Hi there. Firstly, love your guys' videos. I would like to request, if you could, a video on the anatomical differences between pediatrics and adults, and also the stages of development from birth to adulthood.
That's cool.
Obviously, both have a lot to talk about, so I'm sure it wouldn't be one video, or maybe it will be.
Ooh, boy.
I don't know. I'll leave it to you guys. Thanks so much, Joseph.
Thanks, Joseph.
How about I do before birth?
What, and I have to do everything after birth?
I'll do
basically saying you're doing embryology, which you're already doing. I reckon it'll be easier as a podcast. Don't you think? Video, it would have to be multiple videos. I could do one video on looking at the gross anatomical physiological changes. I would have to focus on particular things because it would be impossible to go through it all. But
or you could just do a video on yourself and say how to be a child but an adult.
Oh, so how to be a man-child. You sound like my wife now. All right, Dracus. How would you pronounce that? Dracus or Dracus?
I'd say Dracus.
Dracus. Cool name, by the way, Dracus. I wonder what nationality is Dracus?
Afrikaan.
Oh, it does say there, South Africa. Okay. Appreciation. Good afternoon. I'm currently a 46-year-old student in emergency care in South Africa. I didn't have life science in school. Just want to say your YouTube videos are my go-to. The storytelling way to explain concepts is just above the rest. Thank you. Oh, that's awesome. It helps me to remember words, concepts, and understanding of every aspect. Thank you. All the way from Cape Town. Awesome. Thank you, Dracus. That is brilliant. I've got a couple of friends from Cape Town I play tennis with. They're wonderful.
You play tennis with them in Cape Town?
No, they're from...
It's a long commute.
Yeah, but look, I'd do anything for my sport. No, they're great people. So thank you. Thank you. We really appreciate it. How great would it be to be able to travel to these places and see these people and hopefully see that we'll have some effect or impact around the world. So that'd be nice. You want to do the last email from Demi? Oh, no, second last.
Demi, the subject is AMP, asbestosis, as a form of pulmonary fibrosis.
Yep.
Hi, actually, this is for you.
Is it? Hi, Dr. Mike's chronic bronchitis and emphysema videos have helped me a lot in understanding my coursework and assignment. I tried to find an asbestosis video, but I haven't found it yet. Just wondering if you have made a video on it. Thanks in advance. Demi!
No, we haven't.
No, we haven't. But thank you for watching the videos. The reason why is because when we look at things like asbestosis, for example, at the end of it, it is going to be similar in many. It's going to be a obstructive, result in an obstructive.
Be more restrictive.
Restrictive, yeah, a restrictive form of respiratory disease, and so we tend to try and do videos that cover more than one particular focus. So if I did one on asbestosis, then I'd sort of have to do another one looking at other forms of restrictive
like silicosis and
yeah. So which I think,
but you have done restrictive as obstructive.
Yes. Yeah. So I have done a restrictive video, which I think is quite good. The restrictive versus obstructive video I recommend you watching because that will give you heaps of information in regards to that. So Thank you, Demi. I'm so glad we can be of help. And then the final one's from Claudia, and the subject is pharmacology. And Claudia says, hi, I need help in a chapter for pharmacology. Well, thank you, Claudia.
What chapter would that be, Michael? Are there any other more questions, or that's it?
That's all I've got. Do you have any more? Well, that's all you sent me.
Okay.
I'm sure there's more.
We've got more to get through, but that was...
Anyway, Claudia, feel free to finish the email and tell us what chapter you need help with.
If it's autonomic pharmacology, we could do it now.
As in immediately?
Yeah.
No, we're not doing it now. Jeez. Okay. I hope that helped. Feel free to send us emails. Feel free to tell us how great we are and how much you love me.
And also where in the world, because we like hearing from different locations.
Yeah, so instead of where in the world is Carmen Sandiego, it's where in the world is Dr. Matt and Dr. Mike's listeners. Tell us where you're from and tell us a bit about yourselves. You know, like we love the questions, but tell us, we want to connect with you. Tell us who you are, what you do, what you're studying, where you're from. We love all that. And please know that if you ask specific questions.
Who you prefer, Matt or Mike?
Oh, you don't want that. Don't ask that because you're just you'll quit.
I know.
The show. It's going to be sad for you. I'm going to put out a poll. Dr. Matt or Dr. Mike? Who do you prefer? Who would you rather sit
Please
next to during an exam?
because we all know.
I reckon if the question was who would they rather sit next to them during an exam, I reckon they'd say you.
No, they wouldn't. Just because I wouldn't talk. That's the only reason.
No, it's because you're cool, calm, collected, and I'll be like, and they'd say, shut up, get out.
That's true.
So I think people would prefer you.
I reckon you'd fidget a lot in your exam.
Yes. Yeah, of course. I've got ADHD. What do you expect? I can't sit still on the best of days. I'm going to take my meds before I watch a movie. I watched June last week, 3 hours. Thankfully, I did it in the morning and I took my meds before. And I sat and watched a 3-hour movie for the first time in my life without needing to stand up and walk around the movie theatres.
How funny.
Yeah, so that was good. June is awesome. June 2, part 2.
I haven't seen the first one.
Watch the first one, go see the second one. Brilliant. I watched Oppenheimer also yesterday.
Oh, I want to see that.
Well, over 3 nights. Just for 3 hours. It's on Netflix.
Is it on Netflix?
Yeah.
Oh.
Yeah, that's why I watched it. So over 3 nights. It came out on Friday.
Worth all the Oscars?
It is good. There's not enough Richard Feynman in it for my liking. I think he's a legend. And obviously they focused on Oppenheimer. I think the acting is amazing. The character flaws are good. I don't know. I don't know enough about him in real life, whether they underplayed or overplayed his character flaws. Obviously, you need to make the movie compelling. But I'd be interested to read his biography and then think back on the movie and then see what I think. But it was interesting. It was very interesting and very well done. Watch it.
I will.
But if you want to send us an email, gubiosciences@gmail.com.
Or through the website.
Or go to drmatt.drmike.com.
I think most of the emails come through the website.
All right, go to drmatt.drmike.com.au or Google email Dr. Matt and Dr. Mike. You can also follow me on social media at Dr. Mike Todorovic, at DRMIKETODOROVIC. That's on all good social media platforms, which probably means none of them, to be honest. And TikTok, I'm at DR_Mike_Todorovic. But apart from that, you all have a wonderful week. We will speak to you soon. And
thanks,
Matthew,
Mike.
Thank you. Hi everyone, Dr. Mike here. If you enjoyed this video, please hit like and subscribe. We've got hundreds of others just like this. If you want to contact us, please do so on social media. We are on Instagram, Twitter and TikTok at Dr. Mike Todorovic, at DRMIKETODOROVIC. Speak to you soon.